The following podcast is part of a certified educational activity titled Bridging the Gap to Improved Outcomes in Non-Cystic Fibrosis Bronchiectasis, Ensuring Prompt Diagnosis Through Accurate Interpretation of CT Imaging. Access the entire activity and complete the post-test at peerview.com/VGY860. Downloadable slides and practice aids are also available.
Good afternoon, everyone, and welcome to this program on bridging the gap to improved outcomes in non-cystic fibrosis bronchiectasis. So the goals today are to discuss the disease burden of non-cystic fibrosis bronchiectasis, particularly because diagnosis is often delayed due to poor recognition and underdiagnosis. We hope to show you how to recognize and interpret CT features of non-cystic fibrosis bronchiectasis to facilitate and ensure accurate diagnosis and allow for treatment. And I'm going to talk a bit about unmet needs for patients and how novel and emerging therapies may address some of those gaps. So I'm going to dive right in here to the unmet needs. So what is bronchiectasis? Well, it's a chronic disease characterized by permanently dilated and inflamed airways, usually associated with a chronic and daily and mostly productive cough, not always. The etiology of the word is, it is from Greece. It literally means dilated bronchus. Now, before I go on, I would like to just make a little aside. Bronchiectasis currently seems like it's a little bit of an orphan disease, but it's as old as mankind. As long as there has been tuberculosis, anyone who has had tuberculosis and survived would develop bronchiectasis. The same is true of any other severe or chronic lung inflammation, for instance, the 1918-1919 flu pandemic, which was frequently associated with staph pneumonia, and as you are probably aware, staph pneumonias, again, if you survive, often are associated with bronchiectasis. But between the time of the pandemic and now, bronchiectasis sort of lost its way, I guess, because it was so difficult to diagnose, particularly radiographically. So the biggest problem we have with bronchiectasis is, is lack of recognition, and pretty much that's among clinicians especially. The prevalence is increasing. I think we probably do have a pretty good standardized definition for diagnosis, both clinically and radiographically now, but that has not always been the case, and until recently that was not the case, and not a good referral path. So, for instance, primary care providers particularly don't know a lot about bronchiectasis, and not to be too derogatory, many don't know how to spell it. But I will tell you that when I see a patient referred to me for Mycobacterium avium complex, MAC disease, I spend the first half of the visit talking about bronchiectasis. Patients know nothing about it when they come to us at National Jewish. And that's a generalization, of course, but it's not too far off. We have no FDA-approved or evidence-based therapies. I'm going to talk a little bit about that in a minute. And people not only don't diagnose bronchiectasis, they don't diagnose the important infections associated with them, principally Pseudomonas and non-tuberculous mycobacteria. So this slide just shows, these are 4 studies looking at the mean time from symptom onset to diagnosis, and you'll notice it's not short. Now, I was involved in that first study. It's from an ex-colleague of mine named Brooke Nakotra at University of Texas Health Science Center in Tyler. And it was published in 1995. And just to tell you how unfamiliar people were, one of the people reviewing that paper dinged it because there was no standardized definition of bronchiectasis by CT scanning. That was 1995. So we've obviously come quite a long way since then. So symptomatically, cough is almost universal. Sputum production is variable. We do have people who don't cough and spit, but not a lot of them. Fatigue is huge. That occurs in almost every patient we see. Shortness of breath is variable depending on pulmonary function testing. Hemoptysis is also almost universal. I tell patients that sometime in their life, they're going to cough up blood. Now, it may be a very little bit, but the good news is it's almost never life-threatening and is almost always self-limited. And weight loss is another big one. So this is looking at bronchiectasis prevalence. It's estimated that we have between 350,000 to 500,000 adults with bronchiectasis, and as you might imagine, the prevalence increases with age, so that over 60 is there is significantly more bronchiectasis than people 50 and 40 and younger. It's also more common in women, which if we have a little time, we might discuss. And it is supposedly increasing at 8 to 10% per year in terms of recognition. Now, you know, bronchiectasis is not reportable. It's poorly recognized. So these numbers are almost certainly underestimations. So this will be on the test. No, just kidding. All right, so first we had a vicious cycle, and now we have a vicious vortex. So with the vicious cycle, we have airway abnormalities that lead to abnormal mucus clearance, bacterial colonization, and neutrophil inflammation. This has been modified somewhat. If you have chronic inflammation of the airways for any reason, you're going to have denuding of the cilia from the bronchial tubes. After that occurs, which of course is you lose your mucociliary elevator for sputum when that happens. After that, there is proliferation of mucus glands in the airway. So off the bat, you got 2 strikes. You make more mucus than you should, and you can't get rid of it. Now, the next, what happens next is kind of mixed, and that's why this vicious cycle got changed into a vicious vortex, because all of these things interplay. So the next thing that happened may be colonization or invasion by bacteria and mycobacteria, and concurrently recruitment of neutrophils particularly, but also T cells. But once all of that happens, and particularly once there are pathogenic bacteria in the airway, then you end up with a dilated, non-functioning bronchus. And of course, that is an irreversible process. I also tell patients a lot, once you are, I hate the word colonized, because colonization implies benignity. And I don't believe these microbes are benign in any sense. But once you have Pseudomonas in your airway, it is almost impossible to eradicate it. And of course, Pseudomonas is not the only one that we see for bacteria, but as you know, we also see mycobacteria. So there are multiple etiologies for non-cystic fibrosis bronchiectasis, which is a little bit of a misnomer. In the past and in parts of the developing world, it's almost always post-infectious, kids who get terrible infections when they're young. Now, the hereditary part is important, and even though the title is non-CF bronchiectasis, CF is actually pretty important as a cause of bronchiectasis, even in our adult patients, and we're going to talk some about that. In our practice, the oldest CF patient is in her 80s, and that's true CF. The other one's alpha-1 antitrypsin deficiency, PCD, and immunoglobulin deficiency. Now this idiopathic one is not idiopathic. It's almost surely going to be genetic. And again, that's something we could discuss also later. Now, this is a busy slide, but I want to make it simple. The rate limiting step is right there. Diagnostic suspicion for bronchiectasis. And I got to hand it to you guys. These days, about half of the cases of bronchiectasis that come to us are found because somebody had a coronary artery calcium score, or because they were in the ER and had the inevitable CT pulmonary angiogram, or somebody was looking at their gallbladder and cut the bottom of their lungs. So I just want to say, you guys are critical to the community diagnosis of bronchiectasis. Primary care providers don't know about it. Just more encouragement for you. Whatever you're doing, keep it up. All right, so the other thing I would just point out, the American College of Chest Physicians defines chronic cough as cough for 8 weeks. That ain't very long. And unfortunately, people go months and years without even a chest x-ray who have chronic cough, when of course they should have it very early in their course. So I would say that chest x-ray is probably the next step for most folks. And unless you guys pick it up on a CT, it may take a while to get the chest CT scan. And then the workup for underlying conditions that cause bronchiectasis kind of depends on the status of the patient. So, as it is a heterogeneous disease, and treatment can be difficult. For instance, we normally ask people to do airway clearance with hypertonic saline, and the first question I get is, Doc, am I going to have to do this the rest of my life? And the short answer is yes, which makes me very unpopular. But it depends, again, it's individualized. So what are the objectives of managing bronchiectasis? Well, prevent exacerbations, improve quality of life, and hopefully stop disease progression. That depends a little bit on why they have bronchiectasis. If there's an identifiable underlying reason, you want to address that. But otherwise, it's how we manage it, I think, that helps prevent progression. So airway clearance is number one. You ask any of our patients how you manage bronchiectasis, they're going to tell you airway clearance, airway clearance, airway clearance, because that's what we tell them. So hypertonic saline with a PEP valve is how we start, and then we kind of ratchet it up to vest therapy if necessary, and then there is a new CPAP-like device called the Velara device that also is very effective. Antibiotics are necessary if you have severe or frequent exacerbations. We're going to talk in just a second about that. And then macrolide as an anti-inflammatory. And let me just say, for those of you not familiar with it, the macrolides have an immune modulatory effect distinct from their antibiotic effect. And it's been shown in a couple of studies that the macrolide in bronchiectasis patients reduces the number of exacerbations that they have. So this is a proposed stepwise approach to treatment, and basically airway clearance, an anti-inflammatory drug like a macrolide, antibiotic therapy for frequent Pseudomonas exacerbations especially, and then other treatment modalities as dictated by the severity of the bronchiectasis. So an exacerbation is determined if a clinician feels a change in bronchiectasis treatment is needed. So, usually it's associated with cough, sputum volume, nasty looking sputum, and perhaps shortness of breath. I will say, in my opinion, there is a very fine line between bronchiectasis and exacerbation and pneumonia. As a syndrome, it's essentially identical in my mind. Although I will say fever is less common, I think, with exacerbation than with pneumonia. So what this slide shows is that in terms of hospitalization, the more frequent exacerbations you have, the more likely you are to be hospitalized. And this shows that the more frequent your exacerbations, your survival is less than folks who have fewer exacerbations. So it's bad stuff. How do you prevent them? Airway clearance, consideration of the macrolide, and then antibiotic therapy. Usually to put someone on inhaled antibiotic therapy, we would want to see 2 or 3 exacerbations in a 12-month period. And I can't miss this point. Macrolide monotherapy is terrific in a lot of diseases, including bronchiectasis. But if your bronchiectasis patient has MAC and you give them the macrolide monotherapy, they're going to develop macrolide-resistant MAC, which is horrible to treat. So I know you guys don't control that, but it's good for you to know. If somebody is treating one of their bronchiectasis patients with macrolide, you could at least ask, does this patient have MAC? So we really need more effective treatment to break that vortex. And there actually is a medicine out there. It's a DPP1 inhibitor and targets neutrophil serine proteases and can block inflammation to break that vortex cycle. So this is looking at initial results. The first study that was done with it was a phase 2 trial. The time to first exacerbation was significantly longer in patients who had the DPP1 inhibitor. The name of the drug is Bronchiectasis. That's the generic name. And also, in that phase 2 trial, the amount of serine protease was significantly lower in the people who received the Bronchiectasis than placebo. You can see that once it was discontinued, serine proteases in the sputum went up significantly. There is an ongoing study of Bronchiectasis. It's the phase 3 study. It's quite a large one, but they have closed this study, and there should be results within the next few weeks or months, or a couple of months. Now, just one quick note about eosinophilic inflammation in bronchiectasis. As you can see, there's about 20 to 30% of patients. And IL-5 inhibitors and IL-5 receptor alpha inhibitors do improve those patients with this eosinophilic related bronchiectasis. Now, the caveat here is that inhaled corticosteroids potentiate mycobacterial infections. So in general, unless you have this particular phenotype for your bronchiectasis, we do not recommend inhaled steroids for our patients. And as you can see, there are a number of different approaches, which, by the way, I've been at this for a long time, and I mean, this is just very gratifying. For a disease that nobody can spell, the amount of work that's being done right now, as I say, is quite gratifying. Okay, so I think we've discussed all of these points, and I'm going to turn it over to Dr. Elliker. Thank you very much.
My name is Brett Elliker. I'm from San Francisco, and I assume that most of you, all of you, are radiologists, so I'm going to kind of focus my talk to you, with a radiologist, as I am as a radiologist. I guess one thing I would like to say before even starting, I think one way we can make ourselves much better radiologists is to understand some of the clinical background behind why we're doing what we're doing, and how these patients are treated and what kind of response we expect. So I think it's really great to hear clinical talks to give us some background I'll never forget lecturing at one of the interstitial lung disease conferences with my colleagues from UCSF, the pulmonary medicine people, and one of the very famous pulmonologists got up there, Hal Collard, and said, I love our pathologists, our radiologists, I even think they could see people in clinic. And I was like so honored that a pulmonologist would say that to me. I felt so honored. And then he thought for a second, and he said, well, of course, they would need a lot of supervision. So it's important to know some of this information that behind why we do what we do. So we'll start with a quick case, and we'll come back to this case at the end and show you some of the images. This is a 60-year-old man, productive cough. I was interested to know that fatigue was a significant symptom in bronchiectasis. I was like, I have fatigue. And then I saw Cole's vicious cycle, and I thought, oh, Cole's my oldest son's name, so it's probably related to my kids, not the bronchiectasis. So his cough began several years ago, coughs up mucus plugs and has frequent respiratory infections. Over the past few years, he's lost about 50 pounds. That seems quite significant. And spirometry, FVC was 77% of predicted, FEV1 was 62% of predicted, and the ratio was 68%. And his physician refers him to CT imaging. So as we talk about the findings of bronchiectasis and the differential diagnosis on imaging, think about this case and how you might approach this case from a clinical and eventually we're going to see the images and imaging perspective. Okay, great. Let's move forward. As was already discussed, and as I'm sure all of you know, chest X-ray is quite insensitive for airways disease in general, and bronchiectasis specifically. This is a really nice example of a patient with really advanced bronchiectasis. And this patient had a very severe childhood viral infection resulting in bronchial obliterans, which 50 years later resulted in this chest X-ray. But the chest X-ray was only abnormal very late in the course of disease as the airways became extremely large. So obviously, chest X-ray is very insensitive for bronchiectasis, which is why we really focus on CT scan. Now, here are two different patients. What is the difference between these two? And I would argue that the patient on the left has very significant large airways disease with cystic bronchiectasis, airways inflammation, a little bit of mucus impaction, almost air fluid levels in a couple airways. The patient on the right, the disease is predominantly in the distal airways. And of course, diseases that involve the airways may involve both the small and the large together. Often they do, right? They have combined findings of both. But usually certain diseases predominate in the large airways and certain diseases predominate in the small airways. And we're going to focus on large airways disease today, but you should have a differential diagnosis of both. The small airways disease is a patient with panbronchiolitis who actually got lung transplant. And that tends to be a disease that's very involves mostly the distal airways. So it's going to present with different findings: central lobular nodules, tree and bud opacities, bronchiolectasis, airways dilated way out in the periphery of the lung, whereas other diseases tend to be more central, produce bronchiectasis, airways inflammation, airway thickening, and mucus impaction. And from my perspective, these are the diseases that tend to predominate in one or another. And this is complicated, and we as radiologists might have a different take on this than a pathologist. For instance, chronic bronchitis, in some sense, the distal airways obstruction is probably more physiologically important. But on imaging, we see very little evidence of that distal airways obstruction. We see more central airways disease. And luckily, the correlation between the central airways involvement and the severity of distal airways correlates quite nicely. There's a couple studies that show that. But as getting back to the main point is that certain diseases tend to predominate centrally and certain diseases tend to predominate distally, and these are some of the more common players and how they break down in terms of large or small airways involvement, understanding that most diseases involve both but predominate in one or the other. Of course, thin sections are really critical. Our routine chest CT, actually we reconstruct at 1.25, actually we reconstruct at 0.625, which I wouldn't expect you to do, but our routine chest CTs are under 1.5 millimeter. Obviously in full inspiration. I think in detecting air trapping, it's really important to get expiratory CT on all patients with suspected diffuse lung disease, at least on the first scan. And you'll see cases where inspiration looks pretty normal, or you don't see any evidence of airways obstruction and inspiration, and expiration shows quite a bit of air trapping, so it increases your ability to detect small airways obstruction. So that's our routine protocol at the very minimum. So as Dr. Griffiths mentioned, bronchiectasis is irreversible. Now, that's not often how we as radiologists describe bronchiectasis. We describe it as when we see a big bronchus. We don't really know if it's irreversible without more than one scan. That being said, when we see it on imaging, usually it's not going to go away. There are few exceptions to that. I think one example is you get bronchiectasis in areas of organizing pneumonia that can be reversible. You get bronchiectasis in areas of lung injury that can be reversible. But I would say in the majority of cases, when we see a dilated airway on imaging, it's probably not going to get better, but occasionally will. The classic CT findings, and there's a recent consensus paper that actually defines what should be the definition of bronchiectasis, is an enlarged bronchoarterial ratio. We'll talk more about that in a second. Lack of tapering, which is somewhat subjective, but maybe can be helpful. And then when you see very distal airways that are enlarged, you usually don't see airways in that last 1 to 2 centimeters of the lung. So if you actually can discern airways in the peripheral lung, it probably means that they are enlarged. And then what can be also helpful if you're trying to say, is this bronchiectasis or not, are there supportive findings? Is there airway thickening? Are there central lobar nodules, tree and bud opacities? Are there areas of air trapping on expiratory CT? These are all ancillary findings that can help us determine when bronchiectasis is present. So let's look at some examples. I think on this minimum intensity projection image of a airway, sort of the whole course of the airway, you can see where the arrows are, it really doesn't taper like it should. You should have kind of consistent, smooth tapering throughout the course of an airway. And to me, that's abnormally taping it. It's not getting smaller where the arrows are. When we look at that in cross-section, we see the classic signet ring sign in a large bronchoarterial ratio, measuring the size of the bronchus compared to the adjacent artery. When that is greater than 1.5, you know that's very specific for bronchiectasis. Between 1 and 1.5 is a gray area. There's a couple papers, one which was done in Denver, the Mile High City, where normal people had airways that were in that rate, in that area of 1 to 1.5. And there's a paper in patients over the age of 60 that showed a reasonable number had an enlarged bronchus in that 1 to 1.5 range who had no symptoms and no history to suggest that they had bronchiectasis. So above 1.5, it's almost certainly bronchiectasis. Between 1 and 1.5 is a gray area, and that's where you really look for your ancillary findings of airways disease, such as bronchial wall thickening, mucus impacted, air trapping, tree and bud, things like that. There's another nice example of you shouldn't see airways out that far, right? You're in the last 5 millimeters of the lung. We can follow the airways all the way out, almost to the subpleural lung. That's definitively abnormal. Those are dilated airways. Okay, great. There's two types of bronchiectasis we see, and today we're focusing on inflammatory bronchiectasis, which has a variety of different appearances, which I'll talk about on the next slide, but can be smooth or saccular. But you see a lot of, it's wet inside. It's like, they call it wet bronchiectasis. There's a lot of airways inflammation, wall thickening, mucus impacted, air fluid levels. There's stuff inside the lumen of the airway. That's inflammatory bronchiectasis. That should not be confused with traction bronchiectasis due to lung fibrosis, where the airways are opened up because the lung has scar tissue that's forming around it. That's dry bronchiectasis. It does not have airways inflammation, mucus impaction, central lobular nodules, tree and bud opacities. So that's the first decision point, and the differential diagnosis is totally different between inflammatory and traction bronchiectasis. And then within the inflammatory category, there are 3 general subtypes. Cylindrical, which is mild, varicose, which is more severe, and cystic, which is the most severe, and you get these big saccules. And the importance of that is cylindrical is very nonspecific. You can see with all kinds of things. You can even see with acute infections. But as you go from cylindrical to varicose to cystic, it implies chronicity and severity. But most importantly, it implies chronicity, and it really narrows your differential. There's only a limited number of diseases that give you chronic bronchiectasis that's going to be so bad that you will result in cystic bronchiectasis. It means it's been going on usually for years. And as Dr. Griffith mentioned, it's often not diagnosed until very late in the course of the disease. So we're really now focusing on the chronic causes of bronchiectasis, usually manifested by varicose or cystic bronchiectasis with lots of airways inflammation. And then we talk about distribution, which is very helpful. Cystic fibrosis is one of the very few diseases that produces symmetric mid to upper lung cystic bronchiectasis, like you see on this coronal reformata image. Very classic, and we'll see another very interesting case of this a little bit later on. This is pretty much an Ant Mini. There's middle lobe and lingular predominance of bronchiectasis. You can see the middle lobe is even collapsed, which is another potential manifestation of bronchiectasis. When it's very severe, it eventually produces lobar collapse. Look how there's all this stuff inside the airways, but there's really not pneumonia. There's not consolidation outside the airways. So when you see a lot of intraluminal airway inflammation, very little outside of it that predominates in the middle lobe and lingula, that's going to be non-tuberculous mycobacterium in a very high percentage of cases. And as radiologists, we can really slam dunk this diagnosis. Lower lobe, often these turned out to be idiopathic. Although I would say in my opinion, I think quite a percentage of those idiopathic are probably due to long-standing constrictor bronchiolitis from a variety of different causes, including post-viral. You can see it with graft versus host disease and chronic rejection lung transplant, a variety of medications, inhalational disorders. But this is sort of some of the things that I think about with, again, very significant, severe lower lobe bronchiectasis, immunodeficiency, recurrent aspiration, primary ciliary dyskinesia. If you think that's rare, we see probably a few cases a month of that in our bronchiectasis clinic, so it's not as rare as you think it is. Probably, Dr. Griffith would probably agree, a lot of these diseases are not as rare as you might think they are because they're just underdiagnosed. CF is another example which diagnosis can be challenging. And then central bronchiectasis. This is a nice example of an airway which is really dilated, but it's very close to the hilum. Let's look at that on a soft tissue window. What do you notice about that? Actually, two airways, right? There's one you see longitudinally, and one you see in cross-section. What's the attenuation of the mucus in those airways on the soft tissue window? And the fact that it's both central and it's high attenuation is really classic for this disorder, which is allergic bronchopulmonary aspergillosis. Obviously seen mostly in asthmatics, so occasionally in other diseases like CF. But this is a classic appearance. Central bronchiectasis. Tends not to be as extensive as some of the other diseases we've shown you, kind of patchy. You see a few airways dilated here and there. High attenuation, mucus, because the aspergillus accumulates, I think it's calcium ions or something like that within it. And this is actually post-treatment. You can see how the mucus impaction significantly improves. Okay. And then there are occasional cases you see where the airways are extremely dilated, but they're incredibly thin-walled, which does not follow the Cole's vicious cycle, right? Where inflammation induces more bronchiectasis, and that induces more inflammation, that induces more bronchiectasis. Usually these are inflammatory disorders with a lot of colonization and pathogens in the airway. And this is really interesting. In this case, the walls are very thin, and this is pretty classic for one of the cartilage disorders, the main two being tracheobronchomegaly, or Munia-Kuhn syndrome, and the other one being Williams-Campbell, which I think affects the 4 through 6 order bronchi. Dilated airways that are very dilated, but also quite thin-walled. So maybe think about that in that situation. Those are rare diseases, but you will see those rarely. And then lastly, let me finish off on constrictor bronchiolitis, because I think this is an entity that's extremely underdiagnosed, even within the context of the non-CF bronchiectasis we're talking about today. And it can be very difficult to diagnose on imaging early on. Constrictor bronchiolitis is an entity where something induces scar tissue forming around your very distal airways, but that's way too small for a CT to see, that scar tissue. So what you see is the fact that the airway is obstructed, and you get air trapping distal to that airway obstruction and on expiratory CT, and you also get mosaic attenuation on inspiratory CT, and that's often the only findings early on. But over years, that high airway pressure, as you're pumping through air, you're trying to pressure through air through that area obstruction, your large airways start to dilate. and you start to get large airways disease and bronchiectasis. And this shows the overlap between small and large airways. You can see in this patient with rheumatoid-related constrictor bronchiolitis, that's one of the causes of constrictor bronchiolitis, connective tissue disease. Early on, we just see some heterogeneous lung attenuation on the baseline CT, what we call mosaic attenuation or mosaic perfusion. If you got expiratory CT at that time, you expect to see air trapping. And then 7 and 16 years later, you start to see the airways, the large airways start to dilate and get inflamed. You start to see more mucus, wall thickening and mucus impaction. So this is, I think, one of those underappreciated entities in general, but also can be very difficult to diagnose in more of the stage where the baseline here is for this patient. These patients are generally treated with, I guess, we call it FAM therapy, which is a corticosteroid, azithromycin, and montelukast, which is, I think, proven mainly in the bone marrow transplant patients, but we take it and apply it to these other ones as well. And then, of course, as I mentioned, I want to make this point one more time. Air trapping is, get your expiratory CTs in a first scan and look for areas of air trapping. That's going to increase your diagnostic yield of disease in general, but also increase your ability to determine what is the most likely disease that's causing the patient's symptoms. So it's very important to get expiratory CT. A moment about surveillance. I think, when we follow patients over time, I'd be interested to hear Dr. Griffith's take on this. With interstitial lung disease or airways disease or any diffuse lung disease, we generally use pulmonary function tests to surveil them. And if patients develop worsening PFTs or worsening symptoms, then that's often the threshold at which we get imaging. I do think that there's an important role of imaging in patients in whom PFTs are not super accurate. And I think airways disease may be one of those targets. Early interstitial lung disease is another one, right? To see progression of early ILD, you may not detect that on pulmonary function tests. So I think that it's kind of getting longitudinal CTs can be very helpful in certain circumstances. And you look for, one, superimposed processes like a pneumonia or a new cavitary lesion, but of course also progression of airways disease in general. So my summary is, bronchiectasis is irreversible dilation. Of course, we generally call it just when it's enlarged, but in most cases that is irreversible. And we have this new consensus paper that describes the different features of bronchiectasis. Bronchoalveolar ratio greater than 1.5, between 1 and 1.5 is a gray area. Look for supportive signs of bronchiectasis, non-tapering areas of airways, and seeing the distal airways out in the periphery of the lung. And this really helps us with differential diagnosis. So let's turn to the case that I presented at the very beginning. Chronic productive cough, referred for CT imaging, showed this. I have a few images here. We see a very focally dilated airway up in the left upper lobe. There's a few very peripheral airways here, but most of the disease is in this central lung. Here is an image through the right middle lobe. The right middle lobe is partly collapsed, and we see this structure in it, this high attenuation tubular structure, which is probably an airway that's filled with this high attenuation mucus. And then I have one more image that shows the bronchiectasis in the left upper lobe. Look at the density of that. It's really a beautiful example of this entity, which of course is ABPA. Very good, nice. Here's the serologic tests, eosinophilia, IgE level that's elevated, and Aspergillus-specific IgE and IgG, which I have no idea if those are elevated or not. I assume that those are, Dr. Griffith. Okay. This was a nice example of ABPA. And there are also criteria for how we diagnose ABPA, and imaging is one of those. There are other things, some of which you see here, but imaging is a very important part of that diagnosis. Okay. Do you want to present this case?
This is a 45-year-old man who came to us, an attorney from the South, and he had multiple respiratory infections and recurrent pneumonia starting in childhood. His sputum was culture positive for Pseudomonas, MAC, Mycobacterium abscessus, and I'll show his CT imaging. He had actually multifocal cystic bronchiectasis, but there was an upper lobe prominence in that bronchiectasis. As I said, he had those infections. His PFTs were actually not too bad, but his sweat chloride was elevated to diagnostic levels for cystic fibrosis. He had abnormal CFTR mutation analysis with the F508 delta mutation, as well as one other pathogenic mutation, and he was subsequently diagnosed with cystic fibrosis. Now, the reason I wanted to show this is this guy was 47 when he came to us. A lot of people missed the diagnosis, but a radiologist who could have said, look, have you thought about CF in this guy? Could have been a hero in taking care of him. And some of you may say, well, what's the point of diagnosing CF? Well, I'm sure many of you are aware in the last 10 years, we have new and good drugs for treating specific mutations in cystic fibrosis. It is not a moot diagnosis anymore. It is actually a treatable one. So that's the reason I wanted to show that case. Go ahead, please.
I think we're all set. I think we're just going to get the audience QA. We have a couple questions here. Maybe these are probably both for you. So maybe you can start with that one. I have a couple thoughts about that one too, but.
The first question is about Lady Windermere syndrome, and is it related to voluntary suppression of cough? No. Thank you. I actually never use that acronym, or not acronym, but I don't use that term, Lady Windermere, at all.
So what would you consider the main risk factors for developing that? And so are any of those modifiable?
Not yet, but there is actually a growing amount of information that these patients have multiple mutations in mucociliary clearance, none of which by themselves are enough to cause bronchiectasis. Maybe one in the cilia, one with mucus glands, whatever. But it looks like there is a constellation of these mutations which results in bronchiectasis and NTM disease. Now that is an active area of research now, but I feel very strongly this is a genetic problem.
I guess the other question I have for you is about that question, is that we see quite a few patients with Lady Windermere, not NTM, that are also aspirators. Do you think aspiration has a significant component or no?
That's a tough question.
Yeah. I like to bring them out. So.
Yeah. Well, at National Jewish, we check for both dysphagia and reflux, and just about everybody. And as you might imagine, perhaps you know, what is the prevalence of those two things in the general population?
Yeah, very high.
Yeah. So we find a lot of people who aspirate. Now, what role does that play in the pathogenesis of bronchiectasis, or what role does it play in promoting further progressive bronchiectasis? And I have to say, I just don't know. And just forgive me, one last thought. I mean, a big gap in our knowledge is what is the form frust of this so-called idiopathic bronchiectasis? I don't guess we're ever going to get a chance to do high-risk CTs on girls that are high school seniors, but we don't know. We don't know what it looks like, partly, and again, that's why it takes so long to diagnose. Sorry.
No, it's okay. So maybe that process starts way, yeah.
I believe so.
Yeah.
Yeah.
You want to ask?
Hey, Brett.
Oh, hey, James, what's up?
I don't know if this is on. I don't think it is. I'll just shout. Oh, there it goes. Thank you. James Gruden, UNC. This talk, it made me think, Brett, your talk and your slide showing the traction bronchiectasis, which we see a lot, especially in NSIP, and sometimes it's really severe in fibrotic NSIP in particular. Those patients never get recurrent infections. And I'm guessing it's because their neutrophils and the immune status are not infected, but I guess bronchiectasis just in and of itself does not predispose you to infection, which is interesting because a lot of those patients have really terrible bronchiectasis, but it's something we just never really see.
Yeah, it's a really interesting point. I don't know if you have thoughts about that.
Well, the way that I see them is someone with interstitial lung disease and traction bronchiectasis has a non-tuberculous mycobacterial isolate from the sputum or from a bronchoscopy. So I guess I wouldn't say never, but it is also extremely difficult to know the significance of one of those isolates in a patient with severe underlying lung disease.
Another question that came through is, what should you do when a patient has symptoms of bronchiectasis but CT imaging is inconclusive? Well, I mean, I'd say, what do you mean by inconclusive? It's either negative and they have significant symptoms, or it has an abnormality. So I guess the question would be, if the CT is basically negative, they have cough and mucus production. Do you see that discrepancy?
Well,
I feel like it's uncommon.
I agree, but and this is my bias, and you can help me out here. If I have a patient who's growing Pseudomonas and mycobacteria or another enteric gram-negative from their sputum, but their CT is negative, they have bronchiectasis somewhere. I just don't know how to prove that, because normal airways are not, if you will, colonized with gram-negatives. But I don't know what to do.
I feel like it's an uncommon discrepancy, and if you have that, you usually can find some degree of bronchiectasis, even though it might be mild. So, we want to take one question from the audience there.
Paul Clark from San Antonio. Great talk, guys. Thanks for joining us. And in brief response, perhaps that's that gray area of bronchoarterial ratio of 1 to 1.5. Two questions. The first one being, interesting case on the 40-plus-year-old with CF. Begs the question how one lives to be 40 with a misdiagnosis of CF when it used to be something that killed you pretty early. Maybe I don't know.
I'm sorry, I didn't catch it.
How do patients live? We used to think CF patients only live to 20 or whatever, young patients. How are we finding these patients older with CF?
Yeah,
and I think your patient kind of gets that a little bit.
Is it like sickle trait versus sickle disease, and it's just not for some, it's in incomplete penetrations?
Yeah.
Well, the CFTR modulators have turned CF on its head.
When you have it diagnosed, I just mean you had a 40-year-old and didn't carry the diagnosis of CF. I'm just saying, with de novo bronchiectasis at 40 plus years old, the last thing I would say is CF have you thought about it? Which, back to the initial question, how did he live that long?
Well,
undiagnosed.
You're right. Yeah. I would question de novo. I wouldn't, somebody's not going to present with bronchiectasis at age 40 that didn't have it for years prior to that. Just a matter of referral.
Second question, or maybe third, was the bronchiolitis, so as perhaps a predisposition to then severe bronchiectasis later. Just bronchiolitis, so I'm talking that old classic tree and bud, 20 years ago was always TB until proven otherwise, and so as a radiologist is going to call bronchiolitis. Are you getting sputum cultures on all of them when we say that? And then if so, how sensitive is that to tell you? And what are you seeing in your region as the cause of bronchiolitis there? Well, because it's not always endemic here for TB, so it's going to be something else. What are you seeing?
Yeah, we look for infectious causes universally, but I don't know. I
mean agent. I mean, it's infection until proven otherwise.
Yes.
It used to be TB. What are you seeing as a cause of bronchiolitis?
Yeah, I'm old enough to remember that evolution. From TB now to you name it as cause of tree and bud.
I mean, there's the literature on tree and bud is that it's virtually always infection or recurrent aspiration or whatever, right? It's almost always some kind of infection. And then a small subset of these patients, around 10% or so, have some underlying disorder that leads to chronic infection, like ciliary dyskinesia, immunodeficiency, cystic fibrosis, these kinds of things. So I think that, and there's also a paper that looks at tree and bud and what's the yield of sputum cultures, and it's actually quite low, even though it should be mucus impaction area. We should be able to get sputum up that has diagnostics, so it's actually somewhat low, but I think it's just, they're all patients with infection or aspiration of varying types, and you just have to find it.
Okay, thank you.
Yeah.
Yeah, another thing we frequently see on our CT scans are ground glass abnormalities. Our assumption is the ground glass is not related to mycobacterial disease, but I'm curious what your opinion is of that.
Well, I guess when you say ground glass, my question would be, is it actually mosaic attenuation and the lucent lung is the abnormal lung? I mean, I think when we see bad constrictor bronchiolitis, it produces these big areas of dark lung, right? Mosaic perfusion. And then the blood starts getting shunted away from those areas back into the normal lung, right? And then the normal lung gets hyperdense and looks like ground glass. So I'm kind of wondering, if we're talking about airways disease in general, I wonder if that's what you're referring to. Yeah. Yeah, if you see tree and bud micronodular along with bronchiectasis, does this always mean infection or can be sterile? And I would say that it's almost always infection. There are a very small percentage of non-infectious causes of tree and bud. Follicular bronchiolitis is one I've seen. Injection granulomatosis is another I've seen. Occasionally patients with malignancy will present with intravascular metastases. These are all really rare. So tree and bud equals infection or aspiration almost all the time. And then there's a question on, do you perform expiratory on first imaging or just for the indication of bronchiectasis or for any high-res indication? And the answer is, I do expiratory CT in the first scan for any suspected diffuse lung disease, whether it's bronchiectasis or ILD, right? You can pick up hypersensitivity pneumonitis in patients with interstitial lung disease. So I think it's really important to do good quality expiratory CT on the first scan of any patient with suspected diffuse lung disease, whatever the type is. What else do we have here? For bronchial walls in CT, how thick is too thick? Is this subjective? Yes, I think it's very subjective. The normal wall of the bronchus should just be like a millimeter thick, but that's definitely a subjective thing. I don't know if there are specific measurements.
Just a quick question. If we see bronchial wall thickening a lot in our bronchiectasis population, does that translate to you to some other type of large airway disease, for instance, asthma or bronchospasm?
What?
Just the bronchial wall thickening per
by
se.
itself?
Yeah.
I don't think that really changes, how you think about the case in patients who are underlying, with some underlying clear bronchiectasis. And,
okay.
There are a couple more. How can imaging help in determining treatment for bronchiectasis? How do you? I would actually hear your take on that.
Yeah.
How do you use imaging in those serial follow-up of these patients?
Well, in a couple of ways. First, when I see a patient for the first time that's got iffy diagnosis of NTM disease, more likely than not, I'm going to use airway clearance measures or some other airway approach, and then follow them up with CTs, because frequently you do that, and number one, their radiographic abnormalities like tree and bud and nodules get better, but number two, in MAC patients, about 15% with nodular bronchiectatic MAC are going to clear their sputum with airway clearance alone. So, thank God these are glacial diseases. You never have to fire from the hip. So typically I'll see a person and then 3 months later I'll reevaluate them after they've had 3 months of airway clearance with a study. Now, the second one is most of our patients have infectious disease, primarily mycobacterial disease. So we do a ton of follow-up CT scanning to monitor their response to therapy. And actually that's a little glib, I shouldn't say that. Someone who responds to therapy, I might not do a CT scan for 6 months, and then if they're doing well, another 6 months after that. Our definition of treatment success is 12 months of negative cultures on treatment.
Well, I hope you enjoyed this session. It was fun to give it, and it's a really interesting topic for me. So hopefully you all go back to your practices and have a bit more knowledge about how to make diagnosis of bronchiectasis and the different diseases that result in bronchiectasis. So thanks so much for your attention, and enjoy the rest of your day.
Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/VGY860. This activity is supported by an educational grant from Insmed.